And good morning. It is March 21, 2024. Our patient comes to us from New Mexico. And he has a 19-year history of back pain. 19 years in his lower back. He is also a power lifter, which doesn't help. But he's had back pain at L4-5, L5-S1 for 19 years. Did not want any type of fusion surgery, so he came here for the Deuk laser disc repair. Shot. 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 AP. Okay, our first thing we're going to do is place the needle. And I need both AP and lateral views to do that. Yeah. He has a very deep back. Lateral, please. Very deep. You can see the angle of the needle here is extremely steep. A lot of that is because he's a power lifter. Been a power lifter for years. And yeah, you're all right. So lay still. You're okay. Everything's good. Just lay still. We need you to lay still. All right. We need to get down to the 5-1. Shot. Now you can see he has a little bit of a listhesis at 5-1. Shot. AP. Listhesis means a slippage. We're not fixing his listhesis. We don't need to get rid of the back pain. A lot of people think, oh, if I have a listhesis, I have to have a fusion, but you don't. You don't need to have a fusion. Shot. All right, we're going to work on the other side. Lay still, you're doing great. I'm going to put some more numbing medicine. Yeah. That's enough. Yep. Put it. All right, so the first thing we have to do is get into the herniation that we're going to fix. And we're fixing 4 of them today. So we got to get into four of his herniations. And that's the hardest part is L5-S1. That's what we're doing right now. Shot. L5-S1 is always the hardest. Any questions, Henry? Shot.
At this moment, no current questions.
All right. So far everything's going well for him. He does have some scoliosis. His spine is twisted a little bit, AP. A little bit this side up, left side down, forward. Nice. Everything looking good so far. We're going to make our incision in a moment. I'm going to have a guide wire, 2 guide wires, because I'm going to need to place the guide wire to make the second needle. He's too deep. He's extremely deep back. Shot. You awake?
How you doing, my friend? You okay?
It's bilateral 4-5-5-1, correct?
How you doing? You all right?
You doing okay? Shot.
You having any back pain?
Anything? Not having any pain? Shot? Yeah, it's fine. I know. Well, he's a power lifter. He could probably pick all of us up. And guide wire. So he has 4 spots, 2 discs, bilateral. Bilateral means both sides. Shot. So we got to fix both discs on both sides. That's 4 areas. 4 tears that we have to repair. We've made the incision. I have to get to the second disc. It's going to be the L4-5 on both sides. Shot. Shot. Remember, he's a power lifter, so he's a really big guy. Shot. 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 Let's get an AP. Getting close to the 4-5. You can see the herniation on x-ray. Shot. Perfect. Lateral. So, shot. Yeah, he's taken literally the full length of both needles, which is almost unheard of. So, what can I do over here? I have to make an incision, and I'm just going to have to place another needle here. I don't know, I haven't quite figured it out yet. I think just a needle for now, because I still have a discogram to do. All right, any questions, Henry? Shot?
At this moment, no current questions.
We're going to be doing our discogram in just a moment. Is he almost ready?
How you doing, my friend?
Shot?
You all right? We're going to ask you a quick question, okay? Just relax.
Just lay still.
Just
Shot?
woke him up a little bit, okay? Just nice.
Don't move, all right? You're okay. Don't move. Everything's good. Shot?
Oh, okay, buddy.
Yeah.
You're doing great. Okay.
Shot?
In fact, you're doing great. You're in the operating room. You're doing great. A little bit of pain right there.
Shot? I know. But I can't put him back asleep because we got to do our discogram. Shot? You're fine. Shot? Everything's good. Don't move around so much. You're good. You're good.
Good job. Good job.
Shot? You're okay.
You're doing great.
We're going to have you asleep in a minute. Shot? Yeah, this is right where his painful area is. Shot? Let's go AP.
Where's your pain in your back? Pain in his back.
Oh, did that needle come back?
Really
It
well.
did.
Fantastic.
Shot?
Doing really well.
All right. Lateral. Watch the guide wire. Looking good. We're going to put you to sleep in a minute. Now, he's had lower back pain for 19 years. Right here. I asked him where it hurts. He says right in there. And when you look at his MRI, you can see he has herniated discs with annular tears. Are you comfortable now?
How are you doing? Yes. Just say yes or no.
You having any pain?
Okay. No pain.
No pain. All right, man.
You're doing great.
Have you watched these surgeries?
I watched any.
Huh? Oh, all right. Are you comfy? Yes. Just tell me. All right, good. You might feel something. If you do, let me know how bad it is on a scale of 1 to 10. How bad is that on a scale of 1 to 10?
Give us a number.
How high do you go?
10.
Is that where you get your back pain?
Yes.
Perfect. That's going to be gone, man, when you wake up.
No, you're doing great.
You're doing great. All right.
Snapping it out.
How bad is that on a scale of 1 to 10?
8.
All right, so you got 10 out of 10 concordant. Is that where you get your back pain? Yeah. All right, he gets to go to sleep. All right, whoever's got it, we got 10 out of 10 concordant at 4.5. We got 8 out of 10 concordant at 5.1. So it looks like 4.5 is more painful for him. Just count from 1 to 100. When you wake up, your surgery will be over. All right, so he's got 2 huge tears, actually 4 huge tears at 2 discs. So bilateral tears at 4.5, bilateral tears at 5.1. And when he wakes up, that pain will be gone because we're going to repair his discs.
Try to stay nice and still. You're doing. Just get out.
Take your time. I'll give him a little more numbing medicine. Lay still.
Okay, my friend.
Don't move.
You're doing great.
Lay still. You're doing great. We're putting you back to sleep. All right. So, Henry, let's show our audience, why do these disc injuries cause so much pain? All right, welcome back. You can see, why do herniated discs cause so much pain for patients? And the answer is because of inflammation. This patient, for example, has tears in the wall of his disc in the back wall called posterior annular tears. And the nuclear material from the center of the disc is trying to escape. It's fragmented in pieces and it's trying to come out. And it's that material that's causing all the inflammation. We're going to go in there and clean out the herniation, and that will take care of the inflammation. So the pain goes away after the surgery. All right. Jordan, you can go out. I think. Wait a second.
1 second. Go down.
Maybe not. Looks like we cold welded. Shot?
No. We're gonna.
Shot? Shot? All right, you move the fluoro out. We're good. So I've placed a metal tube called an endoscopic retractor or endoscopic tube right through the tear. So we're not damaging the disc at all. We're actually going through the damaged part of the disc. And you got it? Now we're going to go endoscopically, see the tear, see the herniation, and remove it using a laser. Huh?
I think it's this way. Sorry.
Hold on, let me just see. Let me see. You good?
Yeah. Okay for you?
Patient's fine, yeah. Patient's perfect. Couldn't be better. He's not moving at all. We're just trying to get things situated. So there's our first piece of herniation. to come out. And I can tell you right now, it's hard, calcified. He's got, this disc injury is old. 20 or 30 years old, yeah. And, you know, the injury to the disc may predate the onset of symptoms. So he may have, he may have, look at that. That's a pretty good piece. He may have injured the disc 40 years ago, but then didn't get pain for 10 years. I know we have some questions, so go ahead, Henry.
We have a question from Rom on YouTube.
All right, Rob, fire away.
They asked Dr. Deuk, do you use CT myelogram for diagnostic purposes or just an MRI?
We only use an MRI. You don't need a CT myelogram. Doctors that order CT myelograms, either they don't know what the hell they're doing, or they're making money on the CT myelogram, like getting money off it. And they just want to use you for the money. Either way, you don't want to go to a doctor who doesn't know what they're doing. And you don't want to go to a doctor who would put you through a CT myelogram just to make money. Okay? I'd rather eat Chipotle for a night than put a patient through CT myelogram for the money and not go to the steakhouse. You know what I mean? That's crazy. There's no reason to ever get a CT myelogram unless you're allergic to an MRI scanner. And even then, I wouldn't do a CT myelogram, I'd just do a CT. But, yeah, there's no need for a CT myelogram. And the doctors that order them typically end up, they're the ones who own the CT scan. And they're just trying to make money off it. Because the myelogram, you got to stick a needle in the patient's spine and inject dye. And it's dangerous, it's painful, it's risky for the patient to get an infection or spinal fluid leak. You get dye in that fecal sac and you can actually get arachnoiditis with scarring of your nerves. Look up arachnoiditis, ARACHNOIDITIS. It's horrible. You can get spinal cord injury, you can get a spinal fluid leak, you can get intracranial hypotension, HYPO tension, low pressure in your brain. I mean, there's so many complications. Infection. Why would you ever put a patient through that? The only reason, as I said, is money or incompetence. And I would strongly recommend you stay away from any kind of doctor that would order a CT myelogram. Okay? There's no reason to ever get a CT myelogram. Not unless the patient can have an MRI. And even then, you don't need a CT myelogram. Use a CT. CTs are safe. Watch the needle here. It's like it's coming out. CTs are safe, but myelograms are not. Alrighty. Great question. Any other questions? This is the herniation, by the way. This is what's been pinching his nerves. This is what's causing the inflammation. The white stuff I'm zapping here is all scar tissue around the herniation. So it's herniation and scar tissue mixed together. Now, it used to be just herniation, but then the herniation caused inflammation, and the inflammation caused scar tissue. And now we have calcification. So we have a combination of calcium, inflammatory tissue, scar tissue, herniation, all right here. 4 things. And the laser's a great tool. It's the best way to remove this stuff. You can see the bone down there from his end plate, off to the right at 3 o'clock. It's kind of a pinkish color. Man, this is just one solid mass. I'm going to see if I can grab some of it out. I use a combination of laser and I use the grabber, the traditional pituitary. A lot of times the laser will free up pieces and the grabber will remove them. This patient was asking me before surgery, how do you get those herniated pieces out? And the answer is they float up most of the time. But sometimes you got to grab them out. All right, any other questions?
At this moment, no current questions.
Let's show the video on how the Deuk laser disc repair works.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, welcome back. You can see from our video that the Deuk laser disc repair is a procedure that uses the laser energy guided by endoscopic and X-ray to get rid of the inflammation, but also the source of inflammation, which is the herniated disc stuck in the annular tear. That's what I'm working on right this second. And if you rewind this video about 3 minutes, you'll actually see the pink colored tissue. That is the inflammatory tissue. That's where all the pain comes from. It was right up here in the corner. There's still a little bit left, but just rewind, right? You know, maybe you can go back and look at it. It's on the monitor, but it'll be at the bottom corner, right, Henry?
Yes, it was on the bottom corner.
We call that stuff granulation tissue, because mature scar tissue is white. Beautiful snowy white. Depends on what snow, of course, you're thinking of, but I'm not talking about New York City snow. I'm talking about Montana snow, Rocky Mountain snow. The kind of snow that you think about when you think about drinking a nice cold, coarse beer. Any questions?
Yes, we have a question from Abdul on Facebook.
Abdul, we'll take your question.
They said, "Greetings, Doc. I've just got this question in my mind that why this procedure is not so common and is not performed at a bigger scale. The only place I know of that performs this laser treatment is Deuk Spine Institute. I have not come across any other place performing this procedure while it looks the safest way to fix back problems."
You're right, Abdul. You are absolutely right. We pioneered it. Endoscopic surgery was not pioneered by us. We learned it from other doctors that pioneered it. But the use of the laser to clean the tear, like I'm doing right now, this is what I pioneered here. And unfortunately, for many reasons, most of them financial, other doctors don't do this type of surgery. The financial reasons are quite simple. Number one, to train to do this surgery, you need 1 year of training. Surgeons do not want to take 1 year away from their life and come here to Florida to train. If they live in New York, they don't want to come here and train for 1 year. They have to stop making money for 1 year. That's financial. Number two, the equipment we have to do this surgery costs millions and millions of dollars, about $10 million in total. And so the doctor would have to spend $10 million or borrow $10 million from the bank. And if they don't pay it back quickly, then they lose everything. So there's a lot of risk. I took that risk because I felt that my patients would want this type of surgery because it's better than what else is being offered. And then, you know, to be honest, a lot of surgeons are not comfortable doing the new treatments, new technology. They like to do what they've been told to do during their training. So that's why the companies that sell the screws and rods and cages, the metal companies, they know that. So they go to the university and they talk to the surgeons while they're training, and they become friends with them. and they encourage those surgeons to do more fusion surgeries so that they can make more money. So it's a broken system. Our system is broken, but it's motivated by greed and money instead of what's best for the patients. If it was based on what's best for the patient, everybody would be doing this exact surgery, because I can do all the surgeries. I've trained at the best neurosurgery training program in the country when I did my training, and probably the world. And that program taught me how to do fusions, artificial disc, laminectomy, discectomy, spinal cord stimulator, morphine pumps, you name it, we did it. I did everything. And I came out of training capable of doing everything in the spine. There's no procedure I can't do. But what I found over the years of treating my patients is that they have the best results with this surgery. So that's why I recommend this first for everybody. It's the best for the patient. The best results, the safest, the least chance of complications, the fastest recovery, and the results are permanent. The pain doesn't come back from the disc, okay? Every other treatment, they have problems, complications. So why do the surgeons recommend it? Because they make the most money from those more invasive surgery, and because they don't want to take time away from their busy schedule to learn a new technology. So you're right, it's not in the patient's best interest, and surgeons should always be doing what's best for the patients, in my opinion. So that's one of the reasons I don't get along with the other surgeons very well, is I don't like the character of those surgeons, their moral character. I'm very judgmental when it comes to that. It's one of my flaws. I tend to judge people. All right, we're just about done. A lot of scar tissue here. This is the L5-S1 right side. L5-S1 right side. Next, we're going to do the L4-5 right side. Then we're going to switch the sides and go to the other side. I've removed the herniation now. The foramen is wide open. There's no more nerve compression of the nerve root. There's still a little bit of scar tissue and disc here. Remember, you cannot get all of it as a surgeon. It's impossible. We can only do as best as we can do. But the truth is, it's enough, because the patients have no pain afterwards. And I've been doing this now for almost 18 years. And the results are always the same. 99.6% on average pain relief from the disc. Any other questions, Henry?
Yes, we got a few questions. This next one comes from Ram, once more on YouTube, asking one more question. Are there any cases in which you use interlaminar approach as opposed to foraminal approach?
The only reason the doctors do interlaminar approach for endoscopic is because they don't know how to do transforaminal. Transforaminal is more difficult to do. It's more sophisticated. It requires additional training and competency. If you can't do the transforaminal like I'm doing, then you do interlaminar. So no, I don't do interlaminar because it's worse for the patient. It destabilizes the spine. It removes lamina. It removes ligaments that hold the spine together. So interlaminar is for doctors, surgeons who are not good enough to do transforaminal, or they don't have the equipment. They don't have the equipment, they don't have the training. The interlaminar approach, the UBE, is very popular in Asia and India right now, and it's being promoted by a company that manufactures everything. So they want those doctors doing the interlaminar because that's how they make their money. So they're going around teaching surgeons to do interlaminar, okay? But interlaminar is not better for the patient. It's worse. The nerve is right there. You guys see it?
Yes, we do.
It's in the fat. You see where the herniation was right next to it. Let me get a little bit more. There's still a little bit of herniation right here. I'm going to get that before we leave. That's why you always have to look laterally before you come out completely, because there's usually a piece of herniation lateral. I didn't know to do this when I started doing these surgeries, and I had a patient that had leftover a lot of disc herniation lateral, and I had to go back and do it again. I learned my lesson. So now I always check lateral. Grabber. So we're done with this one. We're going to do the next is the L4-S1 on the left. Sorry, yeah, left. Did I say right earlier or left? Yeah. I meant to say left. I apologize. Earlier I said right. I meant to say left. We're on the patient's left side currently. And we're going to go to the right side next. We're just doing some irrigating. Any other questions?
Yes, we have a question from PA3X on YouTube
Hello, PA3X.
saying you make this surgery look so easy to perform. Very experienced doctor, but I wonder why the surgery is so expensive. I know someone who's in constant pain but couldn't afford the surgery.
Yeah, it's a great question. Spine surgery is expensive. It looks simple to you, but the problem is, what most people don't understand is our clinic, the overhead is over $750,000 a month. Close to $1 million a month. That's almost $12 million a year. So who's going to pay that? I mean, if the patients don't pay it and the insurance doesn't pay it, I can't pay it. So somebody has to pay. Yeah, it's expensive. You're right. It's not by choice. Trust me, I would love to do it for free for everybody, but someone has to pay the bills. So if you can get Bill Gates or Jeff Bezos to make a donation, you know, maybe get Michael Jordan. He's a billionaire. Or Magic Johnson. Or LeBron James. Those guys. Why are they so expensive? I don't know. Why do we pay athletes so much money? Why do athletes make 50, 60, 70, 80 million dollars a year and people can't afford spine surgery? Something's wrong with our society. I think something's wrong with our society. You know, when we get inspected by the government, they come and they check us out. Their agency, they charge $12,000 for one nurse to come for a day. That seems unreasonable. $12,000 for one day for a nurse? That's a lot of money. So why is that charge so high? You tell me. But you know what? If you can fix those costs and bring my costs down, we could charge less. I love when people ask the money questions, because then they actually can get a real education. Everyone thinks surgery is cheap. If we do it in my garage, then it will be less money. Or maybe we just drive a pickup truck. We'll drive a pickup truck around and just stop at the local Winn-Dixie. Hey, look at this. Look at this. I'm hitting it and it's coming back because the pressure. You guys see this? This time it's staying. Yeah. We could just do like a Winn-Dixie run with the truck, jump out, and do spine surgery in the parking lot. Huh? Set up a tent. Yeah. Everybody thinks, oh, it's so cheap. They have no idea. And that $750,000 to $1 million a month cost is with me taking almost no salary. I've had to cut my salary over the years because to make overhead meet. So anyway. Yeah, the truth is that everybody is, the x-ray machine, $170,000 for that machine. I mean, it probably cost them, what, $20,000 to make it, maybe? Less than 20 grand, maybe 15 grand. You know, 15,000, but they charge 10 times that amount. So the problem is, yeah, the television that I'm looking at right now to do surgery, this costs $500 at BJ's, but then if you go, but you can't use BJ's because the government says you have to have a medical television in the operating room, which is no different, and it's $10,000. So the costs to us are ridiculous, and it's all just red tape, bureaucracy, and profiteering. Same TV. I asked the guy, I said, what's the difference between this, what is that, a 60-inch? I said, what's the difference between this 60-inch TV that I'm paying $10,000 for versus the one that's sold at BJ's, you know, at Walmart, basically. And he said there's no difference. It just says medical grade sticker on it. I just about fell over. All right, you guys see the herniated disc right here? The white stuff?
Yes, we do.
It's stuck in the annulus. That's what's causing the pain. It's called an annular debridement because I'm removing the herniation from the annular tear. Great questions. Any more?
Yes, we got a few more questions. This next one comes from Abdul once more on Facebook, asking, "Thank you, Doc. Do you know about any other place performing the laser treatment, specifically in Asian countries?"
Yeah, I don't know of anyone else performing this surgery. I pioneered it, and I'm sure people will be copying us or trying to copy us. But the truth is, if you look at what's called a stealth bomber, you could look at it and say, oh, I can copy that, right? And you can make another stealth bomber, but it's not going to be the same. It's going to be, something is going to be different, wrong, worse, because we have the original, and we've taken the original and we've made it better over the years, made it better. So you can't really understand fully what we do because we show you the whole surgery, but you don't see a lot of the other things like the medications being used. You don't see a lot of the things that are not visible when we broadcast, okay? The positioning of the patient. You don't see a lot of the details. The setting on the fluoroscope. Those are just examples. So nobody can really copy us exactly. And they're going to be worse than us, you know? It's going to end up being worse, not better. Because we've already been there and we've already moved on to make it better. So we're not even, what you see as us now is the old technology, but we're constantly doing and making improvements that are hard for you guys to see because you guys are looking through a camera and listening to me. I don't know if that makes sense. In other words, the Formula One car from, 20 years ago, you look at it, it looks similar to the Formula One car today, but there are differences, and you can't see all the differences. The Formula One car today is faster, but you may not see all the differences because they're somewhat hidden underneath the car, okay? They're called aerodynamic elements, for example. There's also engine, power unit changes from 20 years ago that are better with the turbos and the airflow and the efficiency. So there's a lot of things that you guys don't see. And anybody watching my surgery trying to copy it in Europe or Asia, they're not going to see all the things that make it work really well. Just like you can't see what makes a Formula One car so fast. Because the companies that manufacture those cars, they don't want you to see everything. And it's not that we don't want you to see everything, but those elements are all hidden and they don't talk about them. Okay? That way they have an advantage over their competition. So all the Formula One cars look similar, but if you take the Red Bull, it's the fastest, right? It's faster than a Williams. A Williams will never be as fast as a Red Bull this year with that design. Okay, unless the Red Bull breaks. But you could put Max Verstappen, who's the world champion, from a Red Bull into a Williams, and he's not going to win the race. He's going to lose because the car is not good enough. And you better believe the Williams engineers look at the Red Bull car and say, oh, let's copy everything we can see. But they're never going to make a Red Bull. The Red Bull is too fast. Look at that tear. So look at, when you clean it, it actually closes. Okay? All right, keep the questions coming. These are good questions.
Next question coming from Trisha on YouTube, asking, how do you decide to go in on both sides of one disc? Does it show on the MRI, or do you go by symptoms the person has?
No, it's both. Good question. So I look at the MRI, I get an idea of where the problems are, left, right, both, and then I talk to the patient. And if the patient has symptoms in both legs, I go on both sides. If the patient has symptoms only in the right leg, then I try to only go on the right side. Same thing with the left. Now, if you do the examination and you find that both sides have weakness because the nerves are being pinched, and the MRI shows herniation on both sides, pinching the nerve, then you have to recommend going on both sides. And now, when I make a recommendation, it doesn't mean the patient's going to agree with me. The patient may say, well, Dr. Deuk, you want to do both sides, but I only want to do the right side because my right leg is hurting and that's all I want to do. Okay, fine, then we just do the right side. But that's the patient's choice. It's their body. They have to live with the consequences of that choice. But I'm going to recommend both sides if the patient has weakness on both sides. Now, this patient, I recommended both sides, and he listened to me, and he did what I recommended. And that's going to be good for him because when he showed up, okay, when he showed up here, he actually had weakness in both legs. His left leg was weaker than his right leg. So when I asked him to push his foot up against my hand, there was weakness there. Now you can't find the weakness on a Zoom call. Like I did a Zoom call with him. He's from New Mexico? He's from New Mexico, okay? Which is far away from Florida. He's from, you have to fly 3 hours to get here. So he's from 3 hours away by air. And the first time I met him, I was on a Zoom call. And I can't tell if he has weakness or not. And he said, I don't have any weakness, but he did have weakness. We see that a lot. The only way to know is to actually examine the patient in clinic. And when I examined him, I said, yeah, you have weakness on both sides. The left side is worse. So we were treating both sides anyway because he agreed. So you asked me, how do I determine it? I ask the patient what side their symptoms are on, and then I do an examination when they get here. And I base it on the MRI, the symptoms, and the exam findings, all three. Now sometimes I'll get a nerve test to see if there's nerve damage that I'm missing, on the exam. And the nerve test is also good at picking that up. All right, almost done with this disc, but this is worse than the 5-1. Now the 5-1 was a more degenerated disc. This one is not as degenerated, but look at all the scar tissue. This is all scar tissue from chronic inflammation. His body has been trying to heal this for probably 30 years, 40 years. Yeah.
The last piece that he did was doing so well, I'm going to ask him.
Send them home.
I just want to double check. I always
Yeah.
check with Lena.
She said the pain in her arms is gone.
Yeah, she's doing
Yeah, do you know why the pain in her arms is gone? Yeah, so facet pain can radiate down into the arms, but it can't go past it usually doesn't go past the elbow. So why would her radicular symptoms be better with treatment of the facets? The ones that go past the elbow. The answer is because the facet pain is so bad in some people, it causes muscle spasms. The muscles tighten up and they compress the nerves coming either through the muscles down the arm, or they compress the disc and push the disc out and causes pinching of the nerves. She's doing great. That's good to hear. We're talking about the last patient. You guys did not get to see that surgery. We did it in our room number 2. We don't have a camera in there. And she had cervical facet pain. We did a bilateral cervical Deuk plasma rhizotomy, and her pain is gone, and she's so happy she wants to go home without even seeing me. So yeah, they can go. We won't keep them because we're going to be another 20 minutes here.
She woke up so well, so nice.
Yeah, she's got the best anesthesiologist in the world. Of course she's going to do well. Any other questions?
I also spoke to her husband.
At this moment, no current
Yeah,
questions.
I did too. Her husband is a surgeon. I talked to him. Nice man. He's retired. Yeah. Huh? She's a dentist. I didn't know that. Damn dentist. I never trust those dentists. Finding a good dentist is like one of the hardest things to do. Huh?
I'm a dental folk.
Right? I'm the same way. It's like every time you go there, they want to do cavities or crowns or something. An honest dentist, if you find an honest dentist, keep them. That's the best person. You need an honest dentist.
I gotta get an implant.
All right. Who's your dentist? Oh, yeah? I don't know that doctor. You may have to divorce your husband so you can stay here when he leaves. So you can keep your dentist. Right? Tell your husband he can go. Go to California. You can stay here.
We're gonna miss you, Liz. Very much.
Yeah, we are. You're going to miss us.
You can watch us anytime.
They're going to be working her butt.
You're gonna be getting these questions from Liz in California.
Shoot us a text and let
She's not going to have any time. She's going to be working her ass off over there. All right, just about done. This is the end of the disc herniation. Lots of scar tissue, folks. Lots of calcification. All of this junk. Henry, any questions?
At this moment, no current questions.
If I had to age this herniation, I'd put it at 30 plus years. 30 plus years. Yeah, we're pretty much done here. I'm just literally touching up the final touch-up. To give you an idea, the inside of this metal tube is 5.5 millimeters. So the annular tear, which is smaller than the tube, is about 3 millimeters when we're done. It's going to take a little bit of time for the body to heal it because there's such poor circulation. But the nerve is right up there in that red area, and everything looks good. People ask me, how do you avoid injuring the nerve? Well, I'm a neurosurgeon, so it's my job to do that, not injure the nerve. This nerve at least. All done. Got 2 more to go. Keep the questions coming. He's doing fantastic. He's not even moved a muscle. Right? He's getting the best sleep of his life right now. You use any ketamine or no? Huh, that's nice. Yeah, he's getting great sleep. All right, let's show you. Take that. If I had done a fusion surgery, the incision would be this long. You guys see this?
Yes, we
This
do.
long. That's 6 plus, say 3, about 9 inches long. 9 inches, at least, maybe even 12. Because the deeper the spine is, the bigger the incision. All right, but we have literally a 7, maybe 8 millimeter incision. 2 staples, done. He's going to go home in an hour. I got to do the other side. And you guys can bring the next patient back to room 2 in a little bit.
Now?
No. In a little bit, I said. I just want to prepare them. Shot? All right, any questions?
At this moment, no current questions.
Anybody see any good movies?
Doom 2.
No.
Oh, I loved it.
Come on, dude. Doom 1 sucks so bad.
Oh my god.
No exit wounds? I've heard of that. Maybe I've seen it. It's an older one. Is that an older one? Is it new? And? No. The one with, Napoleon Dynamite's been out for a while,
It's 20 years old.
right? What's his name is the, wait. All right, go ahead. What's his name is the lead actor?
John Hader.
No. The Joker. Yeah, Joaquin Phoenix. He's amazing.
Oh.
That guy's one of the best actors ever.
Agreed.
Guys, wait. Guy's amazing. The Napoleon is 2.5 hours? I haven't been watching any movies lately. I've been so busy with my garden. I feel like I'm drinking from a fire hydrant sometimes. I've taken up gardening and it's very time consuming. If you do it right. Alrighty then. We are now at what, 4-5? No, we're at 4-5. Oh, sorry, 5-1. God, you guys are right. It just looked like this was steeper.
I move it on this side.
Right? How funny. Okay, so we are already on the other side. We are on the left side. Now we're on the right side. We've already done this disc on the left side. And sometimes you'll see a little bit of blood that comes through the disc to the other side. From the other side to this side. Okay, very good. Lots of little pieces. And some big pieces. Any questions?
At this moment, no current questions.
Let's show our audience how do these disc herniations cause so much back pain like this patient's had for 19 years. Welcome back. So you can see from our video how these herniated discs can actually be so painful. It's all about inflammation. Watch the other needle, please. Thank you. Big, hard herniation here. This is hard because it's scarred up, calcifying. It's not hard like a calcium hard, but you can see the gold color. There's some calcium there. Any questions?
No current questions.
Why do we broadcast, people ask? It's because we want to teach people about spine surgery, spine care, spine problems. And because, to be honest with you, this is kind of, you could teach a monkey to do this part. So, I'm not really using much of my CPU. And I'd rather put it to use doing something productive, like teaching. Besides, if I'm teaching, I'm not yelling at my staff. So they appreciate it. Right, Luis?
You never heard us say that.
Huh?
You never heard us actually say that.
I could feel you thinking it. You guys see the blast marks from the laser against the metal? It's just melted the steel. Pretty cool. I love it when people say, I heard the laser can't address bone spurs. They're too hard. Well, how does a bone spur compare to steel? All right. I've probably got 15 more minutes left. You guys see the end plate on the left? That's pink. That's the vertebral body end plate right there. That's some crappy cartilage sitting on the surface of the end plate. All jacked up. Any other questions?
At this moment, no current questions.
There's the tear right there. You guys see it right there? Yeah, it just
Yes, we do.
separated as soon as I hit it with the laser. It's always in the same place. Sometimes it's a little closer to the end plate, either up or lower, but basically it's pretty much right in the middle. You know, it's funny that Boston Scientific bought this laser company, isn't it? Luis, you think something going on there?
You said.
Nah.
You said. That's what is happening. That's why he started with the laser fiber. He started just like you say, monopolying the laser fibers, and then now they take care of the laser as well.
Yeah, but do you think it has to do with us?
I think it's what is it like?
I think it has to do with us. It just dawned on me.
Sabotaging, like what is it?
Boston is all about pain and pain management,
Yeah,
musculoskeletal.
yeah.
Well, they must know that our procedure works. The only procedure to work. It'd be a smart move to buy the laser that I use. I mean, why else buy it? The other treatments that are lasers are used for are prostates, and they don't really treat prostate stuff. But they do treat pain. Never really thought about it until now. We've been broadcasting for 10 years. Their purchase was recent.
Correct. Correct.
My God. Do you remember the head of M&A was here? From Boston?
The guy that came the other day.
You know who he is?
If I know him,
Do you know who he is?
yeah. I mean, no. Like,
He's not just a pain management doctor. He's the head of their acquisitions department for all of their pain. It's interesting that he came. In retrospect, Henry, any questions?
No current questions, but we do have a comment from, forgive me if I mispronounce this, Ernestine on Facebook. Ernestine said, I've had 2 spinal fusions, and I'm still having problems with my back and a lot of pain. I wish I had known about this 5 years ago. Just wow.
I'm sorry. Yeah, we tried. We've been broadcasting for 10 years. 10 years now. And, you know, we're trying to teach people to stay away from fusion. It's totally unnecessary. This is the cure for your back pain right here. It turns out that chronic back pain, which is what you had, 87% of it. Look at the inflammation right there. You see the pink stuff? That's the cause of 87% of chronic back pain right there in the disc. The other place that causes chronic back pain is the facet joint, and it has exactly the same problem. Inflammation. What causes the inflammation? Your body is trying to heal the injury unsuccessfully. And because it can't heal it, it just keeps doing inflammation year after year. That's you moving them, right? So you get pain year after year. And every time you go out and do some activities, you aggravate it and make it worse. And then your body does more inflammation and more pain, and then eventually it settles down a little. At some point, though, it becomes just constant pain. Once you've stirred up the hornet's nest enough. I used to do fusions all the time, because that was the only thing I knew to do to get people out of pain. But my patients were out of pain. 85% pain relief with fusion. That was my average. Lumbar. Of course, laser's far better. Laser, we're at 99.6. I'm having trouble getting to 12 o'clock. Can you help me out, Luis? Is there any?
Feel better now?
It seems a little better, yeah. So what are you using in the next room, Jackson?
No.
3080?
Yeah.
That's 3080 bed?
Correct.
We have a couple questions.
Sure, take them.
This next one comes from Abdul on Facebook,
Hello, Abdul.
asking, Doc, how do you know when stop removing the herniated disc? Like, when do you know that it's enough and do not need to remove any more of the herniated disc?
It's a great question, Abdul. So, remember in the beginning when I first put the tube in, I went deeper and I spent the whole time moving backwards, right? Pulling the tube out. Well, when I put the tube in at first, I put it in at the very deepest part of the herniation. And I used the laser then to clean that, and as it's gone, once I clean it, it's gone, the herniation, I pull back a little bit more, and the whole surgery, if you watch carefully, I'm moving the tube backwards, towards me, towards the skin incision. So what I'm doing basically is I'm debriding from the deepest part to the more superficial part. So you know you're done when you come out of the disc. You've finished. That also makes the surgery safer because it's called the inside-out technique. It was taught to me by Dr. Anthony Young, Tony Young, who's retired. He was in Phoenix, Arizona, orthopedic surgeon, practiced for 30 years, 35 years. And he was trained by Dr. Parvis Campbell in Pittsburgh. He was one of his best students. He took Dr. Campbell's teachings and made it his life's work to improve and build a new endoscope. He did. It's called the YES scope, YESS. Stands for Young Endoscopic Spine Surgery, the YES scope. I will eventually make my own scope as well. But they're not cheap to make. They're very expensive. But Dr. Young taught me the inside-out technique. And that's the way I've done it since the beginning, and that's the way I'll do it till the day I die. It's the best technique. There are other surgeons that start in the foramen or intralaminar, and they start in the epidural space, and then they have a risk of injuring the nerve, the dura, having complications. With this technique, you don't get complications. So somebody said I make it look easy. It's because I have discipline. I do it the same way every time. I do it the right way. Every little step is done properly. Not haphazard. Calculated. Performed and practiced year after year, thousands of surgeries, so you have it exactly right. And you don't get unexpected results. The results are consistent. Damn, do you have to make such loud noises? All right, last disc. Everything went well here. I'm done. Grab her. You can see the epidural fat, the epidural veins, Batson's plexus, Dr. Davis's bald head. Oh shit, did I say that out loud? By the way, we have a patient who wants the hip done. I told him to look you up. They said, can't you do it? And I said, yeah. But Dr. Davis is a specialist. He's special.
Got a short bus special or?
Exactly.
We have a couple more questions.
I may have a couple of answers.
This next one comes from Tracy on Facebook,
Hi Tracy, welcome.
asking, do you feel it's best for patients to avoid ginger tea for a time period prior to the DPR procedures?
It's a great question, Tracy. Should patients avoid ginger tea? I don't know the answer to that. I don't know. I would say it's okay to keep doing the ginger tea. What? Dr. Berndes agrees. Just keep doing it. You don't need to stop it. Huh?
Turmeric and fish oil.
Yeah, but if you're taking turmeric or fish oil, then you should stop the turmeric, fish oil, ginkgo biloba. But I think ginger tea is okay. Scope off? I think ginger tea is probably okay. I'll be honest though, it couldn't hurt to stop it, but if you want to keep doing it, you can. Yeah. All right, one more to go. We've now completed Deuk laser disc repair for 3 of his 4 tears, annular tears. We're doing 4 because he has 4 that are symptomatic. Every patient's different. Some have 1, some have 2, some have 3, some have 4, some have 5, some have 6, some have 7, some have 8. There's typically a distribution though where 2.2 is the most common. 2.2. So it's unusual to have 1 disc that needs to be fixed. It's far more common to have 2 or 3. It's funny because when I looked at my fusion data, it was the same. It was not 2.2, it was 2.5, which is 2.5 discs per patient on average. I have pressure. Other question?
Next question comes from Allison on YouTube. Allison asks, is it possible that after a few years of weightlifting, the hernia can be absorbed back into the disc? Greetings from Brazil.
Hello, Allison. No, the herniation never goes back in the disc, ever. And what they'll do is the doctors will show you an MRI where it looks different. What they're doing is they're showing you a different part, a different cut on the MRI. Okay, I've seen those before on YouTube. It's nonsense, or the internet. Okay, that would be like taking a picture of Luis's face and then changing the angle of the camera slightly, and it looks different, like his nose looks bigger. Okay, from the side. It's just they're playing games with you. The herniations never heal. They never go away. They can shrink a little bit, but they never go away on their own. They feel better for a little while, but they never go away on their own. And if you start being active, the pain is going to come back. The only treatment in the world that gets rid of the herniation permanently is this one you're watching. And it was pioneered here at Deuk Spine 18 years ago. We've been doing it now 18 years, 2,000 cases, 2,000 surgeries. We're the only ones that do this, that I know of. There are people that try to copy us, and I would love to come to Brazil someday. Brazil is one of those countries I really want to visit because of the rainforest, the jungle, the people, the culture. There's so much. Watch it. So, I think Sugarloaf. And of course, that's where one of my favorite songs, a couple of my favorite songs, right? Isn't the girl from Ipanema? Isn't that Brazil?
That's a great question.
I think it
because
is.
I actually did look this up like not too long ago. Hold on.
And then there's Keoma Lambada. Remember that song from the 80s? Da 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 da. Da 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 dee da 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 dee da 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 da.
Girl from Ipanema is Brazilian, correct?
Yeah. Unfortunately, the government has really fucked that country hard, and the people. Stolen all their resources. Corruption is just really bad. But honestly, I can't talk because the United States is far more corrupt than Brazil. And now the corruption in the United States is so obvious, yet we ignore it. We choose to ignore it like it doesn't exist. I don't think we become numb. We've become stupid. We've become addicted to drugs and alcohol. Rather than fighting for what's right, we just accept it. Because we have our alcohol, we got our beer, we got our drugs. We just ignore reality.
We have another question.
For a country that's $30 trillion in debt, how do we justify giving our money away? And taking on more debt. How do we justify all this homeless people and drug addicts on the streets? I mean, our jails and prisons are overfull. Healthcare is not available, not covered for people. I mean, how do we justify all that? People having to pay out of pocket for healthcare, medical debt being the #1 reason bankruptcy. Medical debt. Why aren't the insurance companies? Why are they the richest companies in the world, and yet the people they're supposed to be paying for their medical care, they're not paying? Our system is so broken because of these freaking politicians, and yet here we are complaining about Brazil being corrupt. Anyway, we'll take the question.
Next question coming from Lanu on YouTube.
Wanu or Lanu?
Lanu.
Lanu.
Asking about the herniated disc. What, why do some people have numbness in their hands 24/7 and some people just don't?
That's a great question. The numbness is coming from the spinal cord being affected by the herniation, pinched or irritated. Some people just don't have that same irritation. It has a lot to do with the amount of inflammation. Some people have more inflammation than others, so that's what I would chalk it up to. It's a bit more complicated. It has to do with the amount of space around the spinal cord and the spinal canal that you're born with, and it has to do with also the herniation, and is it harder, softer? The harder ones tend to push more, the softer ones tend to deform more, so they don't do as much pressure on the spinal cord. So it's kind of multifactorial, to be honest, but we do see that quite often. Lots of people have herniations, not everybody has symptoms. So why do people have symptoms and other people don't? It has to do with inflammation, has to do with genetics, has to do with density of pain fibers, location of pain fibers. 5 minutes. There's a lot of variables, none that you can control. The only thing you can control is coming here to get it fixed.
We have another question.
Uh-huh.
This comes from Nashwa on YouTube,
Hello, Joshua on YouTube. Welcome to our live stream.
asking, can cervical disc herniations cause leg pain? And also, can this endoscopic procedure in the disc decrease the disc height?
Yeah, great question. So first of all, cervical disc herniations cannot cause leg pain. Cannot. N-O-T. And does this procedure decrease the disc height? No. If anything, it increases the disc height. And the way it does that is it reduces muscle spasms, which then stop compressing down on your disc. So your disc height goes up. Indirectly, of course. When you have less pain in your neck,
Davis, we're going to go back with the next patient.
you want to bring her back? No, they can go.
Everyone's going over. Everyone's doing great.
Thank you. I appreciate your oversight. It helps a lot. Couldn't do it without you. That's exactly the way an anesthesiologist is supposed to run the ORs. Did I ever tell you about my VA story, the Veterans Hospital in Gainesville with the anesthesiology chief? I never did. So when I went over to the VA hospital in Gainesville, second busiest VA hospital in Florida, okay, one of the busiest in the country, we were having a start time at 9 o'clock, and we were finishing around 2 or 3, and we were doing only 2 surgeries a day, 2.
So 9 to 2? Wow.
9 to 2, and it was 2 surgeries, okay? And they were small, like carpal tunnel, ulnar nerve, that's it. That's all we get done. We had a backlog of surgeries, neurosurgery procedures, literally like 3 months, okay? So when I went there with my chief, we wanted to do more, Dr. Miracle, Rob Miracle. So we went and met with the chief of anesthesia. And we said, listen, we've got 3 months of backlog. We want to get these surgeries done, like as soon as possible. We want to help these vets get out of pain. Can we add 3 surgeries instead of 2? Can we finish our day at 4 o'clock instead of 2 o'clock? You know what the answer was? No. Absolutely not. They do not want to work. That's how they regulate the number of cases and how much the VA spends, by restricting the operating room time. Whereas at Shands Hospital across the street, we could operate till midnight, 1 o'clock in the morning. As many cases as we wanted to do, we did. But at the VA, they only let you book cases that would be done by 2 o'clock. And the chief of anesthesia was the one blocking it. basically he was under orders to not do too much surgery. And those vets would have to live in pain because of that. You know, our backlog was 3 months. The orthopedic surgery backlog was 9 months to a year. And it could all be fixed if they just let us do more surgeries. But they don't want to spend the money. So this is one of the ways the VA system and insurance companies like the VA that they control cost is by regulating the volume. You know, having people and processes, policies in place to basically prevent care from happening. It costs them almost nothing to have a veteran at home sitting in bed, unable to get out of bed because of pain. You know, that doesn't cost them anything. If the veteran dies from pneumonia or DVT, good. The VA doesn't pay. But to actually have to do surgery, spine surgery, they have to pay. And they don't want to spend the money on the vets. There's no excuse for it. None. Except that they're trying to save money. And that's the problem is they lie to the vets. They lie to you when you join, when you sign up to go fight for America's armies or Navy or whatever, military services, they tell you you're going to get lifetime medical care, right? What they don't tell you, though, is that they're going to do everything they can to keep you from getting it. It's disgusting. There's so much dishonesty and corruption. And honestly,
Blue Cross and Blue Shield paying a premium.
so here's the crazy thing. I was so angry when they wouldn't let us take care of the vets. Like so angry. Because what are they paying? A few $1,000s extra a day, right? For literally $100,000 a year, they could fix another 100 vets. But you know what they did instead? They spent $10 billion on a computer system called an EMR.
That's unnecessary. That's ridiculous.
$10 billion.
Handwriting. Congress.
Handwriting, exactly. And they had a great medical record system before. It was called Citrix. Citrix, yeah?
I know Citrix.
No, sorry, Meditech.
I know both.
Meditech. And it worked beautifully. It was one of the best medical record systems I've ever seen. And they some corruption and politics, they're spending $10 billion on a new medical record system they don't even need instead of taking care of the vets and paying for their medical care. That's because they want to line somebody's pocket with money. It's just greed. Anyway, yeah, we have a corrupt system. America is probably the most corrupt country of all. I'm done. Yeah, I'm done. I'm done, Berndes. I don't see any more. I'm going to clean this last bit. We're done. All right, folks. If you have questions, type them up. I'll do my best to answer them. Here's the end of the disc. This is some of the ligament. It's called the posterior longitudinal ligament. And you can see the herniation's gone. All that's left is a 3.5 millimeter tear, which the body will heal. See the gold color? That's calcium inside the scar tissue. It's because this has been going on for a long, long time. Now he's going to go back to New Mexico with his lovely wife. I met her. Actually, I think she's Brazilian. Is she Brazilian? She said she's from Mexico, but she has a Brazilian name. Maybe she's the one asking questions. All right.
As of now, we just have one question from Nashwa, once more on YouTube,
Uh-huh.
asking, also, Doc, is sitting bad after the surgery? I work at a desk. Do you suggest sitting or standing?
Sitting is fine, but you're right. Sitting puts 2.5 times the pressure on the disc than standing. So you're okay to sit after this surgery, but standing wouldn't be so bad either. If you can do the standing, I would alternate between sitting and standing. But basically, you can go back to work the next day if you have a desk job. All right, that's it. I just love cleaning up this stuff. It's so gratifying. This is better than popping pimples. All right, we're done. All right, so you see the hole? Look at that. It's only, remember, the inside of the tube is 5.5 millimeter. That's like 3 millimeter hole. So by cleaning out the herniation, the annular defect closes, and it's going to heal up.
You did very well. Nice patient. Good job.
Any other questions, Henry?
No current questions.
All right, well, you can end the live stream then.
Copy that.
Huh? Scopius?